Before we begin, I'd like to make a brief acknowledgement. McGill University is on land which has long served as a site of meeting exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks the territory on which we now gather. Please leave your questions till the end and leave them in the chat. I assume that's what you want. And please answer a brief survey that will let us know that you were present today. And finally, our rounds today are on teaching, and I will ask Dr. Michelle Elizov, who's known to many of you. She's the Associate Assistant Dean Faculty Development and Chair of GIM Training Program and on the Planning Committee of this particular initiative. Michelle, if you can please introduce our speakers today. Thank you.
Hi, with absolute pleasure, I will introduce our speakers today. So I'll also let them talk a little bit about what this series is, but it's really the opportunity to see the art and science of medical education in our roles as teachers and educators, and I think we're going to have the opportunity to see really how the science of education gets applied in our day-to-day. So I'm very much looking forward to this presentation. We have two presenters with us. Dr.Isabella Albanese is an assistant professor of medicine in the Division of Endocrinology and Metabolism here at McGill. She's a clinician educator and holds a Master's of Health Professions Education from Maastricht University. There's a bunch of us now, so that's kind of fun. We're a bit of a critical mass. She's received, for the work that she's done in supervisory practices in the longitudinal clinic settings in particular, but also in other areas, she's received multiple education grants, including from the McGill DOM in support of her research, as well as the Class of Medicine 1970 Educational Award for Teaching Excellence and Innovation. She also currently serves as the UGME FMD Endocrinology Content Expert, and her ongoing work, I think we'll see very clearly today, aims to really support meaningful, evidence-informed clinical learning experiences for trainees of all levels. And we sometimes forget that trainees of all levels includes those who are going to be our colleagues in the near future. So this is a really important piece of that career trajectory of our learners. She's also joined today by Dr. Katherine Drummond, who is a PGY3 in internal medicine here at McGill. She's also an active member in medical education and endocrine research with multiple peer-reviewed publications and plans to pursue a subspecialty training in endocrinology and metabolism next year at the University of Toronto. So with that, I will happily turn it over to these two excellent speakers and look forward to this wonderful presentation.
Thank you so much, Michelle, for that introduction. Thank you, everyone, for attending today. Our presentation today is entitled Teaching Future Colleagues, in which we'll be presenting our research exploring faculty and resident perspectives on supervision in the longitudinal clinic. So as Michelle mentioned, this is part of the Real Talk in MedEd lecture series, which is meant to support faculty members in their role as teachers and do so by showcasing local work when possible and in an interactive way. So that's what we'll be aiming to do today. There are two presentations per site per year, so across the MUHC, JGH, and St. Mary's, and this is the first of which occurring at the MUHC for this academic year. Thank you to the members of the planning committee who are all listed here. So we have no relevant conflicts of interest to disclose, but as Michelle mentioned, we did receive funding from the MUHC DOM Education Scholarship Grant for this work. So thank you to the DOM for that support. And we'd also like to thank and acknowledge our co-investigators, Alexandra Iacovelli, who's a medical student at McGill, Dr. Vanessa Tardio, who's an endocrinologist here at the MUHC, and Dr. Diana Dolmans, who's who's a professor at Maastricht University. Our learning objectives for today are to provide an overview of longitudinal clinical supervision literature, and we'll review a learning theory called cognitive apprenticeship theory and how it applies to clinical supervision. Then we'll present our research on faculty and resident perspectives on clinical supervision in the longitudinal clinic. And throughout the presentation, we'll have some interactive cases meant for you to reflect a little bit on your own supervision practices. And this is meant to be very interactive, and we encourage discussion at the end as well. So to participate in the interaction, I encourage you to join our VVOC session. So if you're in person here today, please scan the QR code with your phone and it should take you directly to the session. If you're joining us online, please go to the VVOC's website listed on the slide. I also put it in the chat, so you can just click the link there and it'll ask you to enter the session ID, which is on the slide. And it may prompt you to log in, so you can do so through Windows and then through your McGill account. So your McGill email account, you should have access. So I'll give everyone a few minutes to log in. Okay, yeah, and Sylvia has just reposted it in the chat, so if there's any issues. So once you've logged in once, it should be open for the entirety of the session. Okay. Okay, so I'll go to the next slide. If you're still trying to log in, the session ID and the website are listed at the top of the slide, so you can join in at any time through that link and by putting in the session ID. So the first question is mostly to test the polling software and also just to gauge the supervision practices of the people currently joining us today. So I'll ask you, in your clinic, how often do you supervise the same resident over time? Every week, most weeks, occasionally, rarely, or never? So I see we have 14, okay, 17 people are joining, so that's good. So I'll just give people the chance to respond. So I think we have most responses. So if you're joining us late, you can join our interactive polling by clicking the link in the Zoom chat, put in the session ID and log in through Windows through your McGill account. All right, so I'll reveal the responses. So in your clinic, how often do you supervise the same resident over time? So we have a pretty broad distribution, so that's good. Even if you don't supervise the same resident over time, I'm hoping by the end of this presentation, you'll have some pearls to consider including into your supervision practices going forward. Okay. So next, I'll discuss some background literature on longitudinal clinic supervision. So longitudinal clinics really have a lot of benefits for the trainees that participate in them. So especially for students and residents, it's an opportunity to improve their skill development, so their clinical skills. It gives them an opportunity to develop kind of a graduated independence over the course of the clinic. And it allows for longitudinal relationships both with the patients they're treating and with the faculty who supervise them. Additionally, this is a learning environment that really lends itself to the opportunity about learning kind of specifics of a hidden curriculum within that discipline. So things that are not necessarily explicitly taught, but important to know, kind of come out, or it's an opportunity to learn that here. Additionally, for supervisors, longitudinal clinics really provide enriched opportunities for teaching and supervision. So given these benefits, longitudinal clinics are an integral learning experience for residents and often a Royal College program requirement for many subspecialty programs in some form or another. When it comes to clinical supervision, supervisors report difficulties with providing learners with the right balance of autonomy and support. This creates tensions with learners, in particular when the learners themselves perceive there to be an imbalance of what they perceive to be the right balance of autonomy and support. Making it more complex, what a learner values in terms of this balance of autonomy and support really varies by level of training. So in the literature, earlier medical students report kind of needing more spoon-feeding, didactic type of teaching from their supervisors, whereas later year medical students and junior residents report the need for more feedback and coaching and that type of thing. And then furthermore, third year residents and later report the need for more active and self-directed learning opportunities. So why study longitudinal clinic supervision? Well, the literature on longitudinal supervision overall largely comes from medical students in the setting of something called longitudinal integrative clerkships. So for those of you who aren't familiar with this concept, longitudinal integrative clerkships are first of all, based in medical school, and second, they involve integrating multiple different subspecialties over time. So it's different from this, the general kind of clerkship structure here, in which there's discrete blocks of, let's say, obstetrics, pediatrics, etc. Everything is kind of occurring longitudinally for the medical students. So they'll have like a half day of obstetrics followed by a half day of pediatrics, and that occurs over the course of the year. So the literature on longitudinal supervision is mostly based in this setting, which is of course, involving very different learners as it's medical students in a very different setting as it's involving multiple subspecialties and disciplines and not just one specific specialty. And of course, the needs are different as well. Otherwise, longitudinal clinic research is really limiting, and research on learning and supervision is really limited, especially in the resident population. Despite that, longitudinal clinic is really regarded as the most reflective of practice for some disciplines, particularly those that are primarily outpatient-based, like mine in endocrinology. So this is kind of widely regarded as the learning environment in which the learners are kind of experiencing what will most closely resemble their clinical practice afterward. So the reason to study this is really to have a better understanding of teaching and learning in this setting, to better inform supervision practices, and to better prepare residents for their future clinical practice. So we'll go back to some polling. So I'm just putting this back on the slide for those who joined late. So if you're in the room, you can scan the QR code to join our interactive polling. If you're on the Zoom, you can join via the link on the slide, which is also posted in the chat. And again, you can enter the session ID on the slide, and it may prompt you to log in. So just log in through Windows with your McGill email, you'll have access. So I'll just give a moment for people to log in. If you already logged in, it should still be open. Yeah. Okay. So I'll read out our first case. Case 1, you are supervising a PGY4 subspecialty resident in longitudinal clinic. You've worked together for 9 months. The resident proposes a management plan that is safe, defensible, but not what you would do. You'll both see the patient again in 4 months. What would you do? So the options: change the plan to my preferred approach, discuss options, but ask them to modify the plan, ask them to justify and then decide, let them proceed with their plan and reassess at the next visit. So I'll give everyone a moment to reflect and type in your and select your answers. I think we have most responses. Okay. All right, so we have an interesting distribution. So I appreciate the openness to allowing that resident autonomy. So some of us choose to kind of base it on the justification of the resident. Others might let the resident proceed with their plan and have them reassess together at the next visit. Others less open to that. So good. So we'll come back to this concept throughout the presentation and in our discussion at the end. So next, a resident asks, can I run clinic independently this afternoon? For faculty, what factors go into your decision? And if there are any residents joining us today, I encourage you to respond as well. What signals would tell you that you're ready to run a clinic independently? So for this one, you have to type in an answer. Oh, there we go. Medical legal responsibility, that's a good point. Previous experience with the resident level knowledge base, legal obligations, billing considerations. So as they come in, we'll see them and then we can reflect on them once they're all in. How effectively they have functioned, previous experience, how heavy the caseload is. So these are all very relevant, practical things to consider. resident ability, knowledge, knows their limits and when to call for help, so that's important for sure. The patient distribution. Okay, we still have a few, I think, who can submit answers if you want to. Would not consider this viable. Okay. All right. So I think we're not seeing any more answers coming in. So here we have our distribution of answers. So a lot of concerns about liability and responsibility. I should signal that this is with supervision, not necessarily that, or with supervision, with maybe supervision at the end, or we can discuss practicalities of that after. The experience with the resident, the trust in the resident, how long they've worked together, how effectively they function, whether they know to ask for help. So that's very helpful. Okay, so these are just the things to think about and consider, and we'll come back to this in our discussion later on. All right, so next I'll move on to the theoretical framework of our study. So our study was based in something called cognitive apprenticeship theory. So this is an instructional model for situated learning. So situated learning is learning that takes place in the context of real life contextual activities, i.e. learning in a clinic as opposed to learning in a classroom. Cognitive apprenticeship theory is made up of four main principles: method, sequencing, sociology, and content. Our study in particular focuses on method and sequencing. So method refers to the way in which a teacher promotes learning, and sequencing refers to the order in which learning activities are organized, considering task complexity and diversity. So the method principle, which again is the way in which a teacher promotes learning, is further subdivided into 6 principles illustrated here. So the first is modeling. That's the way in which a supervisor acts as a role model for a learner. The second is coaching, and that's the way in which a supervisor kind of provides developmentally appropriate feedback to the learner. The third is scaffolding, so the way in which a supervisor provides support to their learner. The fourth is articulation, so encouraging the learner to articulate their own thoughts and ideas. The fifth is reflection, so encouraging the learner to self-reflect on their own performance. And the sixth is exploration, so encouraging the learner to explore their own learning objectives and work towards those learning objectives. So cognitive apprenticeship theory has been validated as a concept for evaluating clinical teaching, specifically of supervisors working with medical students, and it's been used to inform a theoretical model of teaching and supervision illustrated here. So this model basically suggests a particular sequence of those different principles we discussed in terms of a supervision relationship between a supervisor and a learner. So it suggests that early on in a supervision relationship, learning is really facilitated by the supervisor via role modeling and via scaffolding or providing a safe learning environment. Over time, this progresses to coaching, where learning is kind of co-facilitated between a learner and a supervisor. And then further over time, learning becomes more self-directed on the part of the student, with the supervisor encouraging activities such as exploration and articulation. When studied, this theoretical model really fit well with the experiences of clinical teachers, particularly of those working with more senior medical students over a longer period of time, so in longer clinical rotations. So for that reason, we felt it particularly appropriate to apply to studying supervision of subspecialty residents in the longitudinal clinic, as these are more experienced learners and this supervision occurs over time. So next, I'll move on to our research questions and methodology. So our study aimed to answer the following 2 questions. What are supervisor perspectives on how they supervise residents and how their supervision changes over time throughout the course of the longitudinal clinic? And what are resident perspectives on their supervision, how their supervision changes over time throughout the course of longitudinal clinic? So, and both of these were looked at through the lens of cognitive apprenticeship theory. So I'll explain a bit about what that means. The study took place here at McGill University. The supervisor portion of the study took place within the endocrinology division. So in this setting, longitudinal clinic is structured as a weekly half-day endocrinology clinic over the last 18 months of a 2-year residency. And this is done either under the supervision of one supervisor for the whole 18 months or 2 supervisors for 9 months each. And participants were recruited among faculty who were currently supervising in longitudinal clinic or who had done so recently in the past 5 years. Participants were identified via purposive sampling. Whereas for the resident portion of the study, they were recruited across the broader DOM. So particularly PGY4 and PGY5 and PGY6 residents from medical subspecialty residency programs that had longitudinal clinics in some capacity. So for example, cardiology, rheumatology, gastroenterology. Again, recruited via purposive sampling. And in total, we had 12 resident participants and 12 faculty participants. So this is a qualitative study using semi-structured interviews, and the interview guide and the interview questions were created basically where each interview question reflected a different principle of cognitive apprenticeship theory. So for example, there'd be a question on how supervisors perceive their role modeling or how residents perceive their supervisor as a role model. And then each question also had a component of asking how they perceive that to change over time to reflect the sequencing principle of the cognitive apprenticeship theory. Then interviews were audio recorded, transcribed, and anonymized, and the interview transcripts were analyzed by 2 separate members of the research team, yours truly, and analyzed for themes using a subjectivist inductive approach in an iterative fashion. And basically interviews were conducted until sufficiency, i.e. until no new themes were identified. So I've provided some sample questions here just to give you an idea of the types of things we asked our participants. Things we asked faculty participants included, what are ways in which you set an example as a role model for residents in the longitudinal clinic? How does that change over time? We asked about the scaffolding, so the support, by asking them to comment on how they find what they perceive to be the right balance between learner support and autonomy, and asked them to give examples of what has allowed them to trust residents in the past to be able to afford that type of autonomy. We also asked about scenarios in which they didn't trust a resident and how that changed their approach to supervision and how that changed over time. In the resident participants, we asked very similar but reciprocal questions. So I'll begin by presenting the results of the supervisor portion of the study. And this was published last year in the Journal of Clinical and Translational Endocrinology. So from our supervisor interviews, 5 main themes were identified as how supervisors perceive their supervision and how they perceive that supervision to change over time. The first is treat the resident as a colleague and create a partnership. The second, make clinic reflect real life by increasing volume and administrative tasks. 3, tailor clinic to resident needs and career goals. 4, let residents make decisions and learn from them. And 5, let residents take patient ownership. So I'll explain some of these in more detail and provide some illustrative quotes just to give you an idea of the ideas being represented here. So the first theme, treat the resident as a colleague and create a partnership. So supervisors generally perceive residents at this stage to be equal team members and future colleagues. And over time, supervisors describe developing an interpersonal relationship with their longitudinal clinic resident. And that contributes to a trust between the supervisor and the resident. And that enables the supervisor to provide the learner with more autonomy. Additionally, it also allows for a mentorship type of relationship that extends beyond clinical teaching and allows them to discuss issues like work-life balance, family planning, things like that. They're looked at as a mentor to address those types of ideas. So I'll read out the quote. I'm interested in them as a person, and that grows with time. If you're my long-term fellow, I will work with you. We will be colleagues. I guide them how to achieve their goals, not just work, but also family life. That's why the longitudinal clinic can be a very rewarding experience because you kind of grow with the person. So next, make clinic reflect real life by increasing volume and administrative tasks. So many participants identify there to be a steep learning curve between the end of residency and the start of clinical practice. And one of the most frequently identified gaps is from training to practice is the volume of patients being seen by residents versus the expectations of what the volume would be as an attending. So to address this, some supervisors comment on creating a kind of junior attending type of clinic setup to give them the opportunity to participate in a clinic in a way that is more reflective of clinical practice. So basically the learner would be allowed to kind of run the clinic independently with the staff in the background as needed, available as support, potentially like reviewed retroactively. So I'll read out the quote. A resident can be okay seeing 3 cases in the afternoon while they then graduate and they have 15 patients to see in the afternoon. I think the best way to actually encounter that is to do a transition to staff practice where you can act like a junior staff. Like try putting in 8 patients in the afternoon by yourself and see how they do, and you're always there as a backup support. So the next theme, tailor clinic to resident needs and career goals. So supervisors describe trying to identify residents' needs and career-specific interests, and then tailoring the clinic experience accordingly over time. So for instance, maybe changing the patient populations that they distribute to the learner within that clinic. So I'll read out the quote. If the resident goal is eventually to go into community, the way we set up her clinic will be very different than someone who's focusing on doing something very specific. We tend to discuss that since the beginning and throughout because I think their goals change. Some people start off thinking community. In the midway, they're like, oh, I want to do academia and very specifically this type, etc. So next, let residents make decisions and learn from them. So another theme in this setting is that supervisors give learners the autonomy to execute their own management plans, even if it's discordant with that of the supervisor, as long as patient safety is maintained. And then most importantly, especially if they're able to follow up that patient afterward to see the consequences of the management plan that they chose. So unless there's something grossly not okay with a plan, I usually go with their plan. I think that gives them the self-confidence and the autonomy to feel okay. Like most times when I say something, I'm not being corrected. And I think that's fair because most of the fellows at that level are quite safe. And finally, the last theme, let residents take patient ownership. So in addition to allowing decision-making on the part of the residents, also allowing them to kind of lead the discussions in terms of counseling patients. The quote here kind of illustrates the progression to that type of autonomy. When you're more established with the resident and they feel comfortable, at the beginning, I'm the one doing most of the talking, whereas later they're having the conversation. And that's where I think it should go because it's their patient. Okay, so next, Katherine will present our results on the resident perspectives. So this is preliminary work that has not yet been published.
Thank you, Isabella. So 5 main themes were identified during resident interviews, articulating how medical subspecialty residents perceive their supervision in the longitudinal clinic. The main themes that were identified that I'll go through in more detail in the next few slides are first, residents appreciate being given the autonomy to manage patients independently with support PRN. They expect to learn how to run a clinic from A to Z. 3, they appreciate opportunities to take ownership of patients and their follow-up. 4, supervisors role model both positive and negative behaviors. And 5, and finally, residents appreciate mentorship and career advice provided by supervisors. So on theme 1, manage patients independently with support PRN. Residents are provided with graded autonomy to manage patients independently over the course of their training. They appreciate the responsibility to perform independent assessments and come up with a plan for their patients. Even as resident autonomy increases over time, supervisors still remain available to provide them with support on an as-needed basis, particularly surrounding medical management. Residents express appreciation for this type of hands-off type of support that they're given and feel comfortable turning to their supervisors when they're faced with any kind of uncertainty. Interviewee one comments on this, saying, I think the truth is autonomy means that you still have someone there to support you, but it's not like forced support. In the sense, it's kind of like, calling a friend when you need help rather than it feeling like having someone over your shoulder. But I think that there's certain things that you do, I guess, to get that autonomy or to become really more independent over time. Theme 2, learn how to run a clinic from A to Z. An important learning objective identified by many of the residents was that during their longitudinal clinic, they would learn how to function in a clinic setting. And this was identified as a major learning gap in other training milieus. The residents seek practical tips from their supervisors on the intricacies of organizing a clinic, following patients over the long term, and other administrative tasks. This was illustrated by interviewee 7, who commented, I think the expectations are not just the medicine, but also learning how to triage consults, what labs to order in advance, when to contact patients, when to organize visits in person, when to organize them in follow-up, how to reserve time to follow-up labs, how to reserve time to fill out forms. So it's not just seeing the patients and writing a note and making a plan, but everything that goes into organizing a clinic. So theme 3, take ownership of patients and their follow-up. So residents express wanting to take ownership of their patients and being given different opportunities to participate in their longitudinal follow-up. However, this is achieved to varying degrees depending on how the longitudinal clinic is structured within a residency program and whether the residents are following their own patients in longitudinal clinic or following the patients of their supervisors. Some residents, such as interviewee 1, express a dissatisfaction with the opportunities that they're given to actually play a role in that follow-up. This resident expressed, I think the challenge sometimes with longitudinal clinics is like you see a patient and then you wipe your hands clean and everything falls on the supervisor afterwards to follow up on the bloods or follow up on how they're doing. Nevertheless, this was not a universal experience. Some residents, such as interviewee 10, are much more satisfied with the opportunities that they're given for ownership. And this is in part on behalf of their articulation of their expectations from the outset of clinic. This resident shared, it was important to kind of set the expectation up front that I want to see a bit of everything. And I want to be, with time, treated like you are with respect to the supervisor. Like if there's bloods that are done in the middle of the week, I want to be texted about it. I want to know about it. I want to have to try to make those decisions as much as possible. Theme 4, supervisors role model both positive and negative behaviors. So residents expressed that there was a benefit of working with the same longitudinal supervisor over time in order to be able to observe and learn from their behaviors, both positive and negative, related to medical management, patient interactions, as well as clinical supervision. Interviewee 12 shared the quote, I think that the unspoken side of longitudinal clinic is that it's not just longitudinal with the patients, it's longitudinal with the attending. So it's sort of like you observing them for 6 months, or in my case, it was 6 months. That I think to me was almost more useful than the rest. And what I mean by that is like understanding how different attendings phrase things to people, like focusing on their language, agreeing with it, and sometimes really disagreeing with it, but just seeing how people do it, understanding how they prioritize their time. And finally, theme number 5, mentorship and career advice provided by supervisors. So residents describe developing a close interpersonal and professional relationship with their longitudinal clinic supervisors over the course of their longitudinal clinic training. Some residents identify their supervisors as mentors and will approach them for career advice related to future training, career opportunities, as well as setting up one's practice. This was well illustrated by interviewee 2, who shared, I would call one of my longitudinal clinic supervisors my mentor. And so when I was looking for an attending job, he actually looked over the contract for me to look to see, oh, these are the types of questions you need to ask. And so I find that has been very helpful, like not just in the supervision sense, but in a professional development and career path sense. A lot of advice regarding how to apply for jobs, how to study for the exam, and how to moonlight. So just a lot of the life tips outside of medicine.
Thank you, Catherine. So we'll move on to the discussion. So based on the work we presented today, we think that these are some of the pearls you can consider potentially incorporating into your supervision practices, particularly if you work with more senior residents and particularly if you have the opportunity to supervise them over a longer period of time. So number one, create an authentic learning environment. So as much as possible, encourage learners to follow their own labs, or if you work in a setting where the EMR allows that, certain ones do, like MILE or something like that, you could task it to them. That kind of improves the authenticity of the task, better prepares them. The learners generally appreciate it and get more from their experience. Additionally, kind of progressing to have them increase their patient volume such that when they're near the time of graduation, their clinic looks like something that it would look like in July once they're practicing on their own. And also kind of considering and discussing other limitations and practical challenges like working in a resource limited setting or billing or things like that are very practical in our practices. Second would be allow space for learner decision making, particularly if safe and appropriate, and they have the opportunity to follow. The third, remember your role as a role model, both positive and negative behavior. So just they're really looking to you as an example and how you do things. And then fourth, the guidance you provide really goes beyond clinical. You really often can be seen as a mentor and look to for advice on navigating real life practical challenges like work-life balance, finding a job, family planning, etc. So we have some final interactive cases. So if you logged out, if you don't mind logging back in, so you can just go to the website, it's linked in the chat. And the session ID is on the top of the slide. Oh, perfect. Thank you, Sylvia. And I'll read out the case. So a final year subspecialty resident will finish training in 3 months. Currently in clinic, the resident sees 4 patients per afternoon and the staff sees 12 to 15. You're considering restructuring the clinic to allow a junior attending model such that the resident runs the clinic independently, sees 8 to 10 patients, and you're available for backup support. Would you implement this model? Yes, regularly, occasionally, only with very strong residents, or no? So I'll give people a moment to reflect and answer. Okay, so I think we have most replies. Really? Okay, great. Okay, so we have a distribution, but it seems like there's potentially some openness to this kind of model. For those of you with concerns, what barriers would prevent this junior attending type of model in your clinics? So you can type in an answer to them. Administrative, that's a big one. Yeah, the EMR, yeah. Time to review, lack of admin, read around the cases, yeah. Perhaps resident doesn't want to. That's a fair point. We did have, some, it wasn't the majority, I would say, perception, but some of the resident interviews did identify that those types of models, they felt it was a scut work thing. So then you can't please everyone. But I think realistically in preparing people per practice, there does need to be like a patient volume that reflects practice when they're towards the end of their training. Total workload because you still have to review and sign off. That's very, very understandable. Okay. Yeah, I understand that too. For people who are managing people with chronic diseases, they expect to see you to a certain extent, so you don't want to influence the patient relationship. Administrative billing can be challenging, but the resident must be able to function at the end of residency. Yeah, that's a bit the challenge, the dichotomy. Okay, so I think we have a good mix of responses. So I think we discussed a few of them, but a lot of people identified kind of administrative barriers, clerical support. So these are real practical challenges. Consideration of that we do need to prepare residents for practice, but that the practicalities of the EMR and the admin don't always necessarily allow for the ideal kind of setup. Okay, and then finally, after this talk, what's one supervision strategy you might try in your next clinic? So you can type in an answer. More independence. Yeah, making fellows more responsible for following their own labs. I think that's a big, like, almost hidden curriculum of outpatient specialties. Set expectations ahead of time regarding follow-up of labs. Yeah, that's excellent. Yeah, so gauging what the residents' goals are in terms of career goals or in terms of what they hope to get out of the clinic, I think that can help you guide the experience. Modifying the clinic experience over time and with trust. Yeah, so I think it shouldn't necessarily look the same when you start a clinic versus months later with the same resident. If I had this type of practice, I would assign patients to a resident and follow longitudinally with me as a backup. So that's a good idea, actually, that they can see the initial consult and keep them in follow-up with you. That's a very good idea. Excellent. Okay, I appreciate the answers. Okay, so I think we discussed most of these. So thank you so much for your attention and your participation, and we're happy to keep in questions.
Thank you very much for sharing this very interesting and topical, right? As we all do teaching. Are there any questions in the room? There's no questions in the room. I'll just look, are there any questions in the chat? Okay, it's all about interactive polling. I have a question for you about medical legal implications. So you decide to let the resident follow their own treatment plan. It's not dangerous, but it's not necessarily the best plan. And the outcome is not what you would have liked, perhaps delayed or, you know. What happens to the attending physician who lets the resident do what they want and doesn't necessarily agree, but allows them to continue that? Is there any data on that?
I'm not aware of any data. I mean, ultimately, I think medical legally, the responsibility does fall to the attending physician. So that does have to be kept in mind. And, ultimately, if you don't agree with the decision or you feel there is a patient safety issue, then that's really your opportunity to correct and change. But, and maybe it's variable from specialty to specialty, but in our practice in endocrinology, there's not necessarily like one right way of managing like diabetes. Let's say like you want to start a new medication, you have reason to pick the SGLT2 inhibitor over the GLP-1 or whatever. It's not necessarily life or death decisions, but decisions with nuance that you can have kind of different arguments for why one way might be reasonable and not the other way. So I think it's kind of more decisions with that kind of nuance. But again, like if there's a patient safety issue, you don't endorse it. But if it's like evidence-based enough, justified, and doesn't put the patient at risk, I think it's reasonable. But I do think ultimately you are medical legally responsible for your own patients. So to consider.
Okay, Beth, do you want to unmute? You have a question?
Sorry
Beth,
about that.
Beth
Yeah,
Hazel,
I'm here. Yeah, so I had some very positive experiences running longitudinal clinic using, we had a camera set up at one point. I thought that was a nice balance between monitoring but letting the resident run the clinic. I didn't know if you managed to include any of that in your data.
I don't think anyone I interviewed uses that as a tool, but that's a really interesting idea for sure. I think it allows for feedback in a way, like assuming you watch it after and give feedback, that, I think they might potentially perform differently when you're not in the room versus if you're in the room. So I think it might provide for like some more authentic feedback on the clinical performance and the discussion. So that's really cool. I didn't know people were doing that.
I think that across the board, the residents felt that they felt comfortable, with the data gathering and with the assessment portion of the patient encounter. And when they felt they would benefit from the staff observing their interaction, such as in disclosing a diagnosis or talking about management, sometimes the staff would come into the room with them to directly observe that encounter.
And good for getting their EPAs done too.
That too.
That's true. Yeah.
Thank you, Beth. Emily Trin, you have a question?
Oh yeah, so I just wondering because I've learned a lot about even my own practice and myself through longitudinal clinic supervision. Were there any themes that you identified in your study about what the supervisor learned from their trainees and from this experience in general?
That's a good point. That did come up. I guess maybe not often enough that we didn't classify it as a theme, but that certainly came up, that the idea when there were patients that they were seeing with like uncertainty, it was almost like having a colleague there to bounce ideas off of and come up with a plan together, review the literature together. So sometimes it would be kind of joint learning opportunities in cases that weren't as straightforward.
Thank you.
Thank you. Henri Ménard, do you want to join the conversation? Henri? His question looks like it's about patients' feedback. Do you have any data on that?
I don't. We didn't survey or interview any patients. I will say through the interviews, our faculty identified using patients' feedback a little bit in their assessment of the learner. So to gauge, like, based on kind of the way the patient described the interaction when they then met with the faculty after, it gave them a sense a little bit of the learner performance. So in that sense, but not directly.
And similarly for the resident interviews, some of the residents commented on how the patients would, chat about their supervisors and how it would affect their perception of their supervisors, mostly in a positive regard.
I'm wondering, Michelle, did you want to make any comments? Michelle?
Yeah, sorry, I've had to step in and out, unfortunately. But I think part of what I really love of the work that you've done is both the fact that you've come at it from both the resident and the staff perspective. I think it's been really helpful for people to see and understand also that what we do in medical education is actually supported by research and evidence and thoughtful questions. And, the ability to present more qualitative data is not something that people tend to be as familiar with. So I like the richness of the quotes that you were able to bring up. One of the things I was wondering, though, as you were presenting, in general internal medicine, we actually have built in to the training program requirements the junior attending model. And is that actually part, and is where, so that general internal medicine residents, when they're on the CTU, for example, they're expected to take the lead, not just on the clinical care, but the running of the service and the teaching and the evaluation. Obviously not on day one, but sort of more towards that transition to practice. And I'm wondering if that's a common thing in other training programs.
Not formally, but I think that could be potentially a step in the right direction to addressing those like training to practice gaps that were identified.
Anyways, thank you to both of you. This was excellent.
Mark, Dr. Roger?
Yeah, I wonder if what your thoughts would be about sort of extending this work to core internal medicine trainees. And one of the things that I've often, as a hematologist, reflected on is that their core internal medicine trainees don't really get exposed to what hematologists do. Get exposed to sickest patients in the hospital, and don't have that sort of longitudinal experience,
Yeah.
which, is like endocrinology.
Yeah, it's the same. Mhm.
Do you think your findings would be different, if this was done at a core internal medicine level?
I think the limitation is I don't know. Oh yeah, for sure. So Dr. Roger asked if how this potentially could be applicable in the core internal medicine residency, given that a limitation of core internal medicine residency is that for outpatient subspecialties like hematology and endocrinology, when they rotate through and they do inpatient service, they don't necessarily get a true reflection of what that practice looks like. I think there's potential for applicability. I think where the limitation is like the longitudinality of it, because they come for 2 to 4 weeks at a time. So while we can certainly expose them to outpatient practice, I think the limitation will be like, do we have someone to kind of mentor them longitudinally to refine that, I guess, the clinical skills? But certainly to expose them to outpatient, I think there's opportunity for that. But in terms of like the longitudinal supervisor relationship, that becomes a little bit more challenging in the context of short rotations. Could still be done, like obviously on a different timeline, but looks different, of course. Yeah.
Okay, are there any other questions in the room? Thanks.
Just a comment.
Okay, yeah, just comments. Sorry, there's just comments in the chat. Are there any other questions in the room? Okay, if not, I'd like to thank our speakers today. Very nicely done. Thank you so much for sharing this with us, and continued success with this. Thank you.
Thank you.
Thank you.